I'm gonna start, let's see, it's recording. I'm gonna stop my video and I'm gonna admit everyone in the waiting room. Right now we have 25 people. Okay? All right, good luck, Dr. Yang.
That's fine, thank you.
Okay, it's starting.
Okay, the diabetes thing on your right side.
I see a couple of familiar names already. Dean is there.
Hi, Dr. Yang. How are you?
Good, good, good.
I like your background. It looks exciting.
You know, then I was asking, this is my hometown. I don't know whether you've been there, Nanjing.
Wow.
Oh, beautiful.
Yeah.
Nanjing. Everybody, well, welcome to the Gavin Herbert Eye Institute lecture on diabetes. I'm Dana Collinson. I'm Marketing and Special Events Director for the Gavin Herbert Eye Institute.
In California.
We're going to mute all of the attendees for now. If you have questions, you'll be able to put them in the chat, and either Dr. Yang will see them and refer to them as he's speaking, or at the end of his presentation, we will make sure and ask him those questions that are in the chat and unmute you at the end of his presentation. So to start with, I'd like to introduce Dr. Yang. He's received his medical degree in China and earned his PhD in Japan. Dr. Yang then completed his internal medicine residency at Albert Einstein College of Medicine in New York, followed by a fellowship in diabetes and endocrinology at Beth Israel Deaconess and Joslin Diabetes Center at Harvard Medical School. Dr. Yang joined UCI in 2014 and now serves as the interim chief of Division of Endocrinology, Diabetes and Metabolism, and medical director of the UC Irvine Diabetes Center. Dr. Yang's clinical interests include diabetes, osteoporosis, thyroid, and pituitary disease. Dr. Yang's laboratory studies include insulin action and obesity. So Dr. Yang will start off, and then Dr. Mithil Mehta will join us halfway through, and we'll introduce him at that time. So Dr. Yang, please take it away.
Thank you very much, Dana, for the kind introduction. So we have 30 minutes, try to be on time. It's great to be here, and I see a couple of names I'm familiar with. Good to see you here. So the topic has to do with improved diabetes care with technology. What I try to review is the development of diabetes management over, the past 100 years. The reason 100 years you will see in the next couple of slides. Now, I know some people are very familiar with diabetes, some people are not. So diabetes basically means you have high sugars in the blood. You can see my mouse here. And broadly, we have type 1 and type 2. And type 1 is caused by the immune system messed up and does not recognize your insulin producing cells as your own cells and destroy those cells. So you become insulin dependent, you need an insulin treatment. Usually happens in children, but can be at any age. On the other hand, type 2 diabetes, most people still make insulin, but insulin doesn't work very well, called insulin resistance. And most people just take some pills to treat the insulin resistance, but some people require insulin treatment to overcome the insulin resistance. And mostly, type 2 diabetes happens in adults, but we have a lot of these children now. Type 2 diabetes can be seen reasonably often in children. Now, the reason for diabetes treatment has to do with the complications. Diabetes is a very insidious disease. You don't feel anything with high sugars. When you feel something is really going wrong, usually caused by the complications. It's a leading cause of vision loss, kidney failure, leading to dialysis. Heart attack, of course, may cause death, and amputation causing disability. So it's a serious disease. And today because the topic is so broad, I will mainly focus on type 1 diabetes and the technologies behind the management of type 1 diabetes, showing you how science has advanced the diabetes management over the past, mainly focused on 100 years. And the topics will be divided to 3 major topics: insulin discovery, development, and delivery, and sugar monitoring, artificial pancreas, finally, islet transplantation and cell replacement therapies. Now, diabetes is a very ancient old disease described in Egypt 1500 actually BC, but most of the type 1 diabetic patients died at very young age. The mortality rate was quite high. So this is data from Joslin Diabetes Center, looking at the mortality rate prior to age of 10 is 1,000 patients. You can see before 1914, 824 patients would be dying among, in 1,000 before age of 10. And after 1914, people realized that if you eat more, your sugar, your situation would get worse. And then fasting became the mainstream treatment. The survival rate improved a little bit, but this is what's happening because you don't eat and you have diabetes. The patients lost a lot of weight. Even though you live beyond 10, most people died at age of teenagers. What was revolutionary happened exactly 100 years ago in 1921. It is the discovery of insulin in Toronto, Canada, by these 4 talented, very outstanding scientists. And these 2 are physician scientists, Dr. Best Banting and McNeil and James Callip. So this is a dog. They treated, so they removed the pancreas. As I mentioned, the pancreas has insulin producing cells inside. So they removed the pancreas from the dog. The dog became diabetic. And then they treated the dog with the insulin they extracted from other animals. And the dog survived. So this is the first dog survived from diabetes. So that was in 1921. And then 22, insulin was used in the first patient and was dramatically effective, as you can imagine. And the next year, this is fast so far, second year, Banting and McNeil received the Nobel Prize for the discovery of insulin. If you look at the Nobel Prize website, it says, although insulin doesn't cure diabetes, it's one of the biggest discoveries in medicine. This is not overstated. So you can see this girl showed in the previous slide. Her name is Elizabeth Hughes. She was 13 years old at that time. And fortunately, she received insulin treatment in 1922. 4 months after the treatment, you can see the difference. She actually lived up to 73 with 3 children, and she died from heart attack. You can see the difference insulin discovery made to change people's life. And Donna mentioned I was trained at the Joslin Diabetes Center. The founder was Dr. Joslin in Harvard. So he was the first one who treated diabetic patients with insulin. And I put a picture of Dr. Minot here. A lot of people don't know him, but he was a Nobel Prize winner in 1934 for discovery of a new treatment for a special type of anemia. I put the picture here. He was one of the earlier patients for Dr. Joslin. He wouldn't be able to survive without the insulin treatment. Then there would be no discovery of the new treatment. This is just one example how insulin changed the history, a lot of discoveries. Now, you can see how discovery of insulin was life-saving. The mortality rate, meaning death rate, before age of 10 reduced to 61 over 1,000 when the insulin was available. And to 1950s, the mortality rate dropped down to 1 in 1,000. There's a big but here. Now, even though type 1 diabetic patients could live beyond age of 10, they still died quite young, 20s, 30s, because of, diabetes not really well controlled. They survived for a short period of times, but they had a kidney disease with this blue color here, and when they're getting older, they have a heart attack. So they, usually died quite a young age. The reason multiple, one of which is the insulin was initially extracted from animal pancreas. This picture shows this gentleman was kind of checking the pancreatic tissue from pigs, looking at, whether bone mixed together or anything mixed inside. And this gentleman was grinding the pancreas for the extraction. So 5,000 pigs, only 8 ounces of insulin could be extracted. And because of animal insulin, by its nature, many patients had reactions to the animal insulin and cannot use it very reliably. Of course, another reason is we didn't know how to monitor the sugar levels in the blood, making it very difficult to say, okay, how much insulin you need, because there was no reliable method to monitor the sugars. Now, so the insulin development changed dramatically in 1978 because of the work from Dr. Arthur Riggs and Dr. Keiichi Itamura. Actually, they are from City of Hope. Dr. Riggs was the director of the Diabetes Institute there. What they did was they put the insulin gene here into the bacterial DNA and then put the DNA back into the bacteria. As you know, bacteria can grow very fast. You can, amplify very fast, so that these bacteria made a lot of insulin, and you can purify the insulin from the bacteria instead of from animals. And because this gene was initially from human, so you can, made it possible to produce a large amount of human insulin. This technology now is routinely used in many labs. My lab can do this easily, but in 1978, that was a big deal. And in addition, it's possible to put a different kind of mutations into the insulin gene so that you can modify the insulin action with different activity profiles. So that's why right now, if you have family members who are diabetic, you may be familiar with these insulin in different type of insulin. You have fast-acting insulin for meal coverage. Regular insulin is kind of moderate. We don't use that very often. And this is a little longer-acting insulin. We use more for diabetic in pregnant diabetes patients with pregnancy. And then we have long-acting insulin for the basal coverage. And that's how we treat the type 1 diabetes now, using basal insulin and for the coverage, and use the short-acting insulin for meal coverage. Again, these are all from the science development, discovery of insulin, initially from animals, then from engineering, gene engineering technology. Now, having insulin, the insulin has to be delivered into the body of diabetic patients. The problem is insulin is a protein, and we eat protein, we eat eggs, we eat beef, has protein inside. So the stomach is very powerful to destroy the protein so that the proteins can be absorbed. Similar to, same thing to the insulin. You really cannot eat insulin because insulin will be destroyed easily by the stomach. So insulin has to be injected using syringe. Now we have very fine needle, which is very helpful. This is an old type of syringe, insulin syringe. Now, as I mentioned, we had a basal insulin, long-acting. You know, everybody makes a little bit of insulin during the course every day, basically, to maintain your sugar levels. There was an idea not long after the insulin discovery to deliver insulin using some sort of pump system so that the insulin could be delivered continuously. That was 1963, a prototype of insulin pump. You can see the technology at that time. And right now we have these very small portable insulin pumps, you know, about the half size of the cell phone. And for the kids, we commonly use what is called an Omnipod. The insulin actually is here in the reservoir because they don't need a lot of insulin. And this is a device to provide the signal to the device, to the pump here for the insulin delivery. So these over these 50 years or so, the technology, especially the digital technology, has profoundly changed the way we deliver insulin. Now, you know, injections are injections, needles are needles. If you can avoid injections, insulin treatment will be more acceptable. So there is a inhaled insulin available, approved by FDA. We don't use that very often because of not really very as good as the injection at all. And also going to the lung can be an issue for asthma patients. Now, several companies, this is one from Israel, are developing the oral insulin. You may ask, you just mentioned that insulin cannot be taken orally. So again, here is the technology. So in this specific oral insulin, they put the insulin in a special capsule so that this is very specially designed. The capsule will be intact in the stomach. And after the capsule is moved to the intestine, the capsule will be destroyed. The insulin will be released. Now, insulin is a protein, fairly large protein. The absorption is very difficult. So they put some chemicals together with the insulin so that insulin can be absorbed. So currently, this specific oral insulin is in clinical trial, just approved by FDA last month, going to phase 3 for type 2 diabetes. Just because type 2 insulin can be a little bit not that tightly controlled. Type 1 could be difficult. It went to phase 2, is still going on right now. Phase 2 is still going on right now. So as you can see, over the past 100 years, in terms of insulin discovery, development, and delivery, we really had a good journey into a stage. As a physician, we feel, you know, as physicians, we feel comfortable in managing diabetes, type 1 diabetes, using the technologies available. Now, insulin is very powerful, but if you don't know the sugar numbers, not much can do. So monitoring sugars is so important for diabetes management. So this is the one from 1970s. If you had a grandpa who was diabetic, you may have seen these. At that time, we checked the urine sugar. We had to boil their urine and use a color to have 1+, 2+, 3+, 4+. Wasn't reliable at all. You can see how difficult it was to manage diabetes. And in the 1980s, the glucometer was developed, but required 30 microliter of blood and took 2 minutes for the reading. But now so many glucometers are available right now, just require little blood and 5 seconds. Now the glucometer is using finger stick to take a little blood for the sugars. The problem is you really cannot stick your fingers every minute or every 10 minutes, an hour. It's a lot of finger sticks. So it comes to the technology of continuous glucose monitoring, relying on the technology measuring the sugars under the skin, because the sugars communicate between the blood vessel and the fluid on the skin. So there is a sensor here, senses the sugars under the skin and send a signal to the transmitter. And then you have a receiver here. This is exactly the sensor here. The sugar numbers can be delivered into a cell phone or even your watch. It's very convenient. You can monitor your sugars 24 hours. It's just amazing. Now, there are non-invasive sugar monitoring systems are being developed right now, but the accuracy is really a big challenge right now. It's just still difficult. Now, with the technology of continuous glucose monitoring and insulin pump system, so artificial pancreas has been developed. You know, basically relying on the sugar numbers from the sensor or the continuous glucose monitoring system, and tells the insulin pump the sugar numbers. And the insulin pump would, based on the sugar numbers and the trend of the sugars, deliver insulin to lower the sugars. So 2018, Medtronic closed loop system or artificial pancreas was approved. And 2 years ago, Tandem Control-IQ was approved. The two systems are available right now. So this is really a direction of our diabetic field to advance the artificial pancreas to make the system better to improve diabetes management. So this is just one example how the artificial pancreas improves diabetes. So this curve represents conventional therapy with insulin injection. You can see the sugars, average sugars are higher. And these patients received the treatment from the artificial pancreas. You can see the numbers are much, much lower in this group. In addition to that, you can also see the variability is much smaller in this group. So overall, the closed loop artificial pancreas is very powerful in one, lowering the sugars, two, reduces the variability of the sugars. But we are just starting this system. There are a lot of things we need to work on. We need a faster insulin, better insulin, because the meal absorption is much faster than insulin absorption. The fastest insulin so far cannot catch up with the rising of the sugars. Also, low sugars, we need another hormone called glucagon, because the pancreas makes glucagon to raise the sugars when insulin is overdosed. And the problem is the glucagon is unstable in a liquid form. It's hard to put in the pump. Now, of course, we need a better AI system to manage the correlation between the pump and the continuous glucose monitoring, to be precise, not too fast, not too slow. And because everybody is different, even in the same person, the time morning and evening could be different. No matter how good the artificial pancreas is, it can never match or replicate the natural islet cells. Islet is a structure or tissue containing the insulin-producing cells. They're just impossible. You can see these numbers here. The pancreatic islet cells evolved over millions of years. They can measure blood sugar levels every millisecond. And the best pump CGM, continuous glucose monitoring system we have, can measure sugars every 5 minutes or so. And also, after sensing the sugar levels, the islet cells can precisely produce just the right amount of insulin, just the right amount. So that's why the sugars are maintained in that very narrow window. So for many, the holy grail of type 1 diabetes research remains the cell replacement therapy, meaning give back the islet cells to the patients. The artificial pancreas is a great tool, but the best precise way is considered to be the replacement therapy. So this is the last topic regarding the islet transplantation and the cell replacement therapies. Again, this is a pancreas. It's a digestive organ. Majority of the tissue is called exocrine for the digestive function. Only a small 2% of cells are either called alpha cells, most of them called beta cells. These are the insulin producing cells. So after the insulin discovery, people were thinking about doing the islet transplantation from the people who passed away. Of course, this is an idea for many, many years. So the technology has been developed to enable some sort of success. So what the technology is to remove the pancreas from the donors. The islets are collected and then put in the bag and infused into the liver, because you really have no place to put in the native pancreas. Has to be in the liver right now is the best place you can do. And then in the liver, there are a lot of small capsules containing blood. And these transplanted islets will sense the sugars in the blood and deliver insulin for the patients. Now the problems are, of course, a lot of problems. We really have limited resource. And because of the isolation extraction process, we lose islets, and one pancreas usually is not sufficient for one specific patient. We usually need more, and you can see how difficult to get 2 donors for one patient. Of course, because the pancreas, the islets are from the different person, and the type 1 diabetic patients need immunosuppressants. And the best scenario so far, the patients can be insulin independent for about 50% of cases. And most people, the transplants kind of expire in 1 or 2 years. Now there comes to another technology called stem cell derived islet replacement therapy, because the availability of native islet cells is so difficult, whether we can make the islet-like cells. So the stem cell technology has been going on many years now. And it's quite not difficult at all to produce the insulin producing cells in the laboratory. Even my laboratory can do that. It requires 6 steps to change the stem cells into insulin producing cells. The color green here reflects insulin production. We have a lot of challenges using this technology. The production of insulin producing cells is clearly not 100%. There are a lot of other cells mixed together, which not supposed to be there for the native or natural islet cells. And if you do the gene production, a lot of genes just weird, different should be there. And of course, the stem cell derived islets, the patients still have to take the immunosuppressants because it's not their islets. And so far, a lot of success in laboratory, a lot of success in the animals. And there's no proved success in humans. And we are doing that right now. And UCI is actually Diabetes Center is doing that together with a company called ViaCyte. So they uses the stem cell derived therapy for type 1 diabetes. What they are doing is to change the stem cells to the precursors of islet cells, and then put in a bag and put the patient's skin under the skin actually, with the idea that the immune cells will be blocked and the cells will produce insulin and other hormones for the patients. The problem is we're having is the cells end up dying because they don't have a blood supply into that. So the specific patient we were using was to put some holes on the membrane, and the blood vessel can grow in to supply the blood nutrients to those cells. The problem, of course, from that is you expose the cells to the patient's immune system, and the patients have to take the immune suppressants. So again, this is still under development right now. Over the past 100 years, from discovery of insulin to the synthesis of human insulin, and the development of continuous glucose monitoring, and the beginning of the artificial pancreas, beginning of cell replacement therapy, has dramatically changed the way we manage diabetes. And I can't really predict the next 100 years, but the next 10 years, clearly this is most likely will be happening. Much better artificial pancreas system with the AI system, better insulin, better monitoring system. And we will see a lot of advances in the cell replacement therapy hopefully without immune suppressants. I didn't touch base on this. This is a very hot topic too. The early detection of type 1 diabetes before its onset to prevent the destruction of insulin producing cells. So we are hoping to find those patients who have the risk to have type 1 diabetes in the future, and we can manipulate their immune system so that they don't attack the insulin producing cells to prevent the happening of type 1 diabetes. All right, that's all from me. I think we're right around 30 minutes. Thank you very much for attention. I don't know whether we have time for a couple of questions.
Yes, we do. If anybody has questions, we can unmute you, or you can pop them in the chat and we can answer from there.
So people are able to unmute themselves at this point. Unless they're a little shy.
If nobody has a question right now, maybe they will after Dr. Mehta's presentation, and then we can have both of our physicians answer at the end of the presentation.
Great. Let me share. What do I do? Share screen. Oh, so should I unshare, or you can unshare me?
Oh, did you want to stop sharing?
Yeah, I can. I just try to see how do I stop sharing.
Dr. Mehta, do you have your presentation?
Okay.
Awesome.
All right, so Dr. Mehta, let's unmute you. There you go. So our next speaker, thank you, Dr. Yang. That was fabulous. For those of us who are not medically trained, that was a lot to take in, but it was eye-opening. So thank you very much. Our next speaker is Dr. Mehta. He graduated from Massachusetts Institute of Technology, and he then completed a Master of Science degree in Physiology and Biophysics at Georgetown University and earned his MD degree from the University of Southern California. After completing his ophthalmology residency at the University of Cincinnati, he graduated from fellowship training in vitreoretinal surgery at New York Eye and Ear Infirmary of Mount Sinai. In addition to the care of patients with vitreoretinal disorders, Dr. Mehta teaches medical students, residents, and is the fellowship director of vitreoretinal surgery. He does research in surgical devices, techniques, and vitreoretinal diseases such as diabetic retinopathy and macular degeneration, and has started a company that makes augmented reality glasses that help people with retinal diseases to see better. So, welcome, Dr. Mehta, and we'll do the same with you. We'll have chat questions during the lecture, and then we'll unmute people at the end, and they can chime in.
Sounds good. Can everybody hear me?
Yep, everything sounds good, Dr. Mehta.
And you can see my intro screen.
Yes, diabetic eye disease.
Excellent. Great talk, Dr. Yang. That's a great study. The artificial pancreas is really cutting edge stuff that we're doing here at UCI. And I'm glad that we're able to actually get patients enrolled in it, because that's the current future, is creating an artificial pancreas. And then eventually, like you said, preventing type 1 diabetes is really the goal of all diabetes education right now. Our next step here is treating diabetic eye disease, and we're going to go over the details of kind of how it works. I'm going to stay a little bit away from the science and go more into the clinical aspect of diabetic eye disease. So diabetes can cause vision loss in several different ways, but it comes down to two general concepts. The first one is cataracts. A lot of people know what cataracts are. It's the clouding of the lens in your eye. It happens to everybody if they live long enough, but in diabetics it happens younger because the sugar itself actually damages the lenses and causes it to become cloudy in younger people. And so we can do a surgery where we take this lens out and we calculate a new lens just for you and put a plastic lens in the eye. Another thing that diabetes causes is a lack of blood flow to the eye, and this can cause a lot of different problems. I'm going to go over a lot of the details of it, and then I'm going to show some pictures of kind of what I'm talking about. But one of the more dangerous things that diabetes can cause is neovascular glaucoma. This is when new blood vessels block the drainage canals of the eye, and the eye is an enclosed system. So then the pressure of the eye goes up, and this pressure damages the nerves of the eye. When you lose vision from nerve loss, like diabetes-related glaucoma or diabetic retinopathy, once the nerves are dead, they don't come back. So you really want to prevent this as much as possible. And when it does happen, fix it very quickly. The thing that I treat mostly is diabetic retinopathy. So diabetic macular edema is swelling of the retina due to diabetes. The vitreous hemorrhage is when you bleed inside of the eye. And a tractional retinal detachment is when scar tissues grow on the surface of the retina, and they can cause vision loss that way. So diabetic retinopathy is the leading cause of blindness in working age people in the United States. Even in patients who do everything right, at least 5% would benefit from surgery for diabetic retinopathy. Our goal for patients is to have a hemoglobin A1C of less than 7%, because this has been shown that if you are less than 7%, you're less likely to develop a proliferative diabetic retinopathy, which causes vision loss. Ultimately, it's a disease of blood vessels. So we want to control the blood pressure as well, and we want patients to not smoke, because smoking also damages blood vessels. So the vision loss from diabetic retinopathy comes from the fact that the blood vessels in the eye become damaged by the diabetes. They leak into the retina and they cause the retina to swell. The body tries to grow new blood vessels. New blood vessels are fine in your arm, but they really don't work in the eye because the eye needs to be clear. Because if you have leaky blood vessels that are bleeding, suddenly you can't see so clearly because you're looking through blood. So we want these blood vessels to not be new, because all the new blood vessels you had them in utero when you're in your mother's womb, but not when you're an adult living your life. And we also don't want scars in the retina, because those can also damage the retina and distort the vision as well. So symptoms that you're going to have with diabetic retinopathy, you can have it without having any symptoms until it becomes advanced. This is not a painful disease unless the pressure goes high, which can cause pain. So early on, you might not even notice any decreased vision, but over time, the vision can get blurry, distorted, or dark. This can happen very gradually or all of a sudden. You can become blind in one or both eyes, and that's what we want to prevent and fix. So there's two general types of diabetic retinopathy. There's the non-proliferative type and the proliferative type. In this context, proliferative means growing new blood vessels. We call this neovascularization. So the treatments for diabetic retinopathy in general are control the sugar, control the blood pressure, cholesterol, and do not smoke. Again, all of these things affect your blood vessels. And ultimately, we want your blood vessels to be as healthy as possible. Even after you do control it, there is some damage. So we have to wait for your body to heal it. Sometimes it'll never heal it. So we have to do treatments like injections in the eye of medication. Sometimes we do lasers and sometimes we do surgeries as well. So this is what a normal eye looks like in cross section. This eye happens to have a contact lens on it, but you see the cornea is the front part of the eye. This is like a window into the eye. You have the iris, which is the colored part of your eye. In my case, it's brown because I have brown eyes. You have the lens that's behind it, the lens that becomes cloudy and causes a cataract. There's the vitreous, which is basically jello, the collagen fibers that fill up the majority of your eye. Think of it like blowing up a balloon, but filled with jello. That's the vitreous. Then there's the retina, which are the neural tissues that line the wall of your eye, and they connect via that little cord in the back, which is the optic nerve, which goes to your brain. When I look inside your eye, this is what I'm seeing. This is the macula. Everything that's in the center of this area here is the macula. The optic nerve is the circular thing. Can you see my cursor or no? I'm assuming not.
Yes, we can see it.
You can see my cursor? Okay. So this is the optic nerve, and then these are the blood vessels. So these thick ones are veins. These little ones are arterioles that supply the blood to the retina. The retinal blood vessels here supply the inner part of the retina, but the outer part of the retina is fed by something called the choroid, which is underneath the retina. So there's two blood vessel sources of the neural tissue in the eye. So when people have non-proliferative diabetic retinopathy, or NPDR, they start to look like this. You start to see these little hemorrhages, little bleedings, and these little aneurysms, we call them microaneurysms, that leak out this protein, this golden colored stuff we call exudates. These are all cause damage to the vision. And when the blood pressure is high, you start to see these vessels become like corkscrews. They become a little what we call tortuous. And you see these little twisty blood vessels? That's because a high flow causes the blood vessels to become squiggly, for lack of a better term. Think of it like a garden hose that's running at full blast, or like a fire hose that's flopping around. It's kind of what happens here, but it doesn't happen quite so violent as that. We then do these angiograms where we put an IV in your arm. We do this in the clinic. This doesn't use any radiation. And we put this plant-based dye in your arms, and this flows through your whole body, and we can take pictures of your eye every couple of seconds, and we look in to see how the blood flows. And when it leaks into the retina, it causes these kind of hazy white areas. We call this leakage. So it leaks into the retina. And you can see these darker areas where there's no blood flow. So you can see the dye didn't leak into this area at all, and there's no blood vessels in this area. All the little capillaries in this area have died. So this area cannot see anymore. So we want to make sure that we treat this area to keep the blood flow active, but not leaking everywhere. We always take these scans called OCT scans. And these OCT scans are using a laser to see a cross section of your eye into the back of the retina. So a normal one is here in the bottom. So it has this little dip here in the center called the foveal depression. So this is the center part of your vision. Everything outside of this tiny little area, this is a fraction of a millimeter. Everything outside of this area is technically legally blind. It sees less than 2200 once you get outside this area. So if this tiny little area is effective, you suddenly don't have reading vision anymore. You'll be able to see the front door, but you won't be able to see details, fine details. So if you see above here, this is what happens with diabetic macular edema. You get these large cystoid spaces in the retina. And this obviously distorts things and it makes your vision blurry. So what we do is we give injections of medication in the eye. Now, I know this sounds scary, but it really is not as bad as it sounds because we numb the eye very well. So it doesn't hurt when we do these injections. The worst part of it is probably putting the drops of iodine in your eye to sterilize it so you don't get infections. Like when you were a kid and your mom used to clean your wounds, like you have got a scrape with iodine. We use the same thing in a much diluted form to sterilize the surface of the eye so we can give an injection. We typically give injections in two different places, either behind the eye in the subtenon space you see underneath here. We can give an injection underneath the eye. Some people do above. I like to do underneath. Or we can give an injection through this area called the pars plana, which is behind where the iris meets the sclera here, where the cornea meets the sclera, and before the retina starts. There's an area here with no blood vessels and no nerve tissue So it's safe to inject in this area. So, but first we obviously numb it so you don't feel pain during the injection time. I do a lot of these injections every day. I think I did 15 today. We do these all the time. I've done thousands and thousands of them. And they're really not that bad. People come in frequently for these injections. The most frequently we'll inject someone is typically every 4 weeks, but most people do it less frequently than that because they control their blood sugar and they don't need as many injections. So there's two general types of injections we do for diabetes. We do something called anti-VEGF or vasoendothelial growth factor. And there's several different medications that do that treat not only diabetes, but also macular degeneration and vein occlusions. You may have heard of those terms as well. There are different medications that do more or less the same thing. Technically, Avastin is off-label for use in the eye, but we use it because it's pretty similar of a medication to Lucentis, but it costs a fraction of the price. So we typically start with Avastin because it's very effective, and we give those injections in the eye. Sometimes we'll inject a steroid to decrease the swelling in the eye. And there's several different brands of medication we use and different types of medication we use. But they all typically do the same thing, and that is to stop the swelling of the retina and improve the vision. And we do them at different frequencies depending on the medication and how well the eye responds to it. So we'll look at the eye frequently to make sure that it's responding well and people are getting better. This is an example of someone with proliferative diabetic retinopathy, or PDR. You see the arrows pointed at new blood vessels. You see these kind of fine, lacy blood vessels and a little bit of hemorrhage you can see around here from where these blood vessels bled. We want to prevent these blood vessels from growing to begin with, but if we already have them, we want to give a treatment of the retina to prevent the body from producing them. And that's by blocking that factor, VEGF. That's why we give these anti-VEGF injections. But those medications, they don't last as long. And people don't want to get injected in their eye every month for the rest of their lives because most diabetics are relatively young. So they have many years left to live because now, thanks to Dr. Yang, we can control their blood sugar. And so they can live to be 100. There's no reason that they can't. I have 100-year-old diabetics in my clinic. So this patient was supposed to have a laser to the retina, but they missed their laser appointment. So then those blood vessels bled a lot, and suddenly their eye was full of blood and they couldn't see anymore. And I can barely see the retina. I can see a little bit in the periphery, but I can't really see the central retina to see whether or not I need to do surgery or move this blood to help them see better. So I do an ultrasound here. This is what we call a B-scan ultrasound, where it can help me look inside the eye when I can't see with my own eyes. And you can see the blood floating around in this vitreous cavity. So this is another patient who had proliferative diabetic retinopathy, and this is the angiogram of what that looks like. You can see the bright areas of the new blood vessels, and you see all this dark area. These are all areas where the capillaries have all died. So the patient has no vision in any of this part of the retina. So they're more or less in kind of a tunnel vision, but you don't notice that because that happens very slowly. So this patient's central vision was actually not that bad. It was 20/60, which is not great. It's not what you're used to, but it's still fine to be able to read large print, watch TV, see your family and function for the most part, and maybe even drive during the day. But it's not what you want, especially since you have all these blood vessels. This could get pretty bad. So we set this patient up for laser. We call this PRP, or pan-retinal photocoagulation laser. So we lasered all of this peripheral dying retina to prevent the growth factors, the VEGF growth factors, from growing. But despite that, they still develop scar tissue. You see all the scar tissue here? And the scar tissue now has stretched the retina. You see these big cystoid spaces. Compare that to before. This is the same patient. And you see that there aren't the cystoid spaces, but you have some scar tissue here, but it's not too bad. But soon afterwards, it stretched the retina out. Now they can't even read the big E on the chart. Their vision is counting fingers, which means I'm literally holding my finger in front of their eyes and saying, how many fingers am I holding up? Because they can't even see the big E. So this is not really sustainable for someone to be able to function with vision that bad. So at this point, we have to do surgery. And when we do the surgery, we remove the vitreous jelly, we remove the blood, we peel off of these membranes, off of the surface of the retina to relieve the traction and allow the retina to go back into its regular place. And so when we finish the surgery, the eye looks great. This is the same patient after having surgery, and the vision is back to 20/60. So back to the vision they had at baseline. And you can see these laser scars, they're kind of bigger spots. We treated the entire peripheral retina. We gave extra laser all in these areas, but we're able to clean off the entire center of the retina, and the vision was restored back to normal. So with better control of the sugars, better medications, better tools and technology, we can lead to better vision. And we're able to do all that here at the Gavin Herbert Eye Institute of UC Irvine, because we have all of the newest technology here, and we have all the techniques and surgeons who can do these procedures. The UCI retina team is 5 retinal surgeons. Dr. Baruch Cooperman is the chairman of ophthalmology here, and he's a retina surgeon as well. Dr. Stephanie Liu, Dr. Mohammed Riazi, myself, this is me, Dr. Mehta, me without glasses at least, and Dr. Andrew Brown, who's a researcher as well as a clinician in our department. This is what the Gavin Herbert Eye Institute looks like. Thank you. If you guys have any questions, we'll be happy to take them now.
All right, you all should be able to unmute yourselves if you have any questions. I didn't see any questions in the chat.
Yeah, or if you're shy, you could also just type questions into the chat as well if you're on a computer. It's kind of hard if you're using your phone.
All right, we had a question come in that says, what about diabetes? What about diabetes damages the blood vessels in the eye? Is it the high level of blood glucose? Can blood glucose spikes in non-diabetics or pre-diabetics also damage the eye?
So we typically don't see pre-diabetics or regular people with glucose spikes because they're very short-lived spikes actually cause damage to the eye. But it's the maintained high pressures of the eye, high sugars of the eye that damage these cells called pericytes that line the blood vessels in the eye in particular, and throughout the body, the kidneys and the brain and the heart as well. And it causes the blood vessels to become leaky. And as a result, they don't allow just the oxygen to transmit across the walls of the eye. It actually has fluid transmit across the blood vessels as well, which damages the eye and decreases the blood flow and the oxygen levels to different tissues, which causes damage to the heart, the kidneys, and the eye. Dr. Yang can give us more details if he wants.
Right, so yeah, very good point. So diabetes, the criteria, now we diagnose the patients, the fasting sugar 125 above, we call them diabetic. The old criteria actually was 140 before 1997. The reason we lowered down the criteria has to do with the retinopathy, the eye complications. So what happened was if you look at the data to look at the patient sugars, there is a sharp increase of retinopathy, meaning diabetic eye disease. If the sugar, so if you look at my finger, it's kind of flat. There's not much of increase of retinopathy, but as soon as the fasting sugar reach 125, you see kind of very sharp increase of retinopathy. So that's why we set the fasting sugar 125 as a diagnostic criteria to prevent the retinopathy. The similar pattern you see with what is called A1C. What is the average sugar in 3 months? We set that as 6.5. Similarly, we see a sharp increase of retinopathy. So that's the point is high sugars damages the blood vessel, the cells of the inner vessel, causing issues. So your question, the answer is yes. High sugars is the reason for the retinopathy.
So even if you keep your sugar below 7, like Dr. Yang said, 6.5 is really what we want. But a lot of these criteria were put in place before we were able to control a lot of the other risk factors for early death and mortality, frankly, from diabetes. So now Dr. Yang likes to keep people less than 6.5 on their medications if we can, but it's a lot easier said than done, right? So if I have a patient who's if I get them less than 7, I'm pretty happy about that. We obviously want them lower than that to prevent other damage, not just to their eyes, right? Their kidneys, their heart. Every time anything damages the eyes, you know there's damage somewhere else. It's just that I can see it in the eye just by looking. I don't have to do any radiology tests to look at that. So we really want to maintain the sugar as best we can. 6.4 is really the goal, but some people, that's just not possible. So we do what we can. And the injections do make the vision better, and they do treat some of the damage, but some of the damage is permanent. Some of the times people do say they are completely recovered, but usually they notice a difference. Sometimes it's color vision, sometimes it's something called contrast sensitivity, where you're seeing subtle differences between colors. But that happens with age to begin with anyway, so we do what we can really in these patients. Dr. Yang, someone had a question about intermittent fasting as a treatment for diabetes.
Okay, I don't see the question. So just add to that, your point is very well taken. Sugar is one factor. Blood pressure is important. Cholesterol is important. So it's a kind of comprehensive management together. So if your sugar is a little bit high, you want to control your blood pressure better, cholesterol lower down further. So this is a triple threats. If you have high blood pressure, high sugar, high cholesterol, those are the killers. So, I mean, the better way to control everything, but if you cannot, try your best to control at least 2 of them. All right, okay. We have a couple of questions. Do you want to go through one by one?
I can go ahead and we have one that says COVID is showing impact to the eyes. What have you observed in type 1 patients who have contracted COVID?
I haven't seen any type 1s with COVID. I've had a lot of type 2 patients with COVID, some of whom did unfortunately pass away. And you know, COVID's a bad disease. It just really is. And it's gonna be worse in patients who have diabetics. They're just higher risk for the morbidity and mortality of COVID.
Yeah, I haven't seen the data publishing out, you know, this is a new disease. COVID is connected to what is called a hypercoag situation, meaning it's easy to have blood clots in the lungs, in other areas. I'm not recording any specific reports on eyes, but as Dr. Mehta said, you know, it's a bad disease. In the diabetic patients, it's even worse. The mortality is higher for diabetic patients.
Do injections make vision better or treat the damaged eye permanently, meaning completely recovered?
Yeah, I did comment on that already.
Yeah.
It helps. That's why we do it. We do it to make the vision better, and it does help.
Does having glaucoma make a person more susceptible to neovascular glaucoma?
No, so primary open angle glaucoma, which is another form of glaucoma, is a completely different form of glaucoma, but the end thing we're trying to control is the pressure of the eye. So if they have neovascular glaucoma on top of regular primary open angle glaucoma, it's worse because their optic nerve is more susceptible to high pressures. And so it could cause blindness, permanent blindness.
Okay. Dr. Yang, I don't know if you've answered this one yet, but they've asked what you think about intermittent fasting as a treatment for diabetes. I think Dr. Mehta mentioned this question earlier.
Yeah, very good question. Yes. So intermittent fasting can cause weight loss, control diabetes. The problem is you really cannot do that forever. So you can use that as a tool to temporarily improve things. It's very successful in animals. In humans, we have some data. And remember, when you are fasted doing that, you have a lot of stress to your body too. The stress hormones actually go up. There are a lot of things, secondary effects. But in terms of weight loss and diabetes, sure, it works. But just in case other things, say you have heart conditions, if you do that, it stresses your heart. And there are other factors you have to consider comprehensively whether you want to try that. And also, as I said, you cannot do that forever. So
we have another person who's asked if hypoglycemia, low blood sugar, affects vision in the long term, and if so, how?
Well, hypoglycemia and low blood sugar could kill you. So obviously, if you are dead, you can't see, and you can cause all sorts of problems with hypoglycemia too. In older people, we tend to be a little more concerned about that, and we tend to be a little relaxed on the A1C numbers just to prevent them from getting these severe hypoglycemia episodes. Dr. Yang, perhaps you can
Right,
elaborate.
so no, I agree. So hypoglycemia, when it happens, you have a lot of stress hormones secreted. So that's why you are shaky, you have excessive sweats. Actually, a lot of people's blood pressure goes up dramatically. So as there's a lot of damage to your body. Of course, eyes, I'm not familiar with that field, but when your sugar level is low, you have blurred vision. For the long term, I'm not sure because again, one severe episode of hypoglycemia does trigger a lot of reactions. And potentially you may several days later, you have some eye issues. Nobody knows it's related to hypoglycemia or not. The bottom line is hypoglycemia is bad, very bad actually, even worse than a little bit of high sugars. So that we try to avoid that.
Okay. Is there a limit on injections administered per patient? Are there any side effects, and what is the process post-injection like?
Yeah, so there's no such thing as a free lunch. Any medication you give can have side effects. The biggest concerns with injections is a possibility of infection. Anytime you enter the eye, you're always concerned about infection because the eye is immune compromised. It's basically separate from the immune system. So if you get any infection inside the eye, it usually causes a big problem. But it's a really low risk because we do a lot of these, and so we try to prevent infection. So our infection rate's somewhere in 1 in 3,000 to 1 in 5,000. So it's pretty rare, but it does happen. So that's the biggest concern is with infection. But that's the main thing. It's also the iodine we use to the eye is pretty irritating to the surface of the eye, especially if somebody has dry eye. So we do tell people to use artificial tears every hour after the injections for that day at least, just to help rinse the iodine out afterwards. The eye is usually red for about a week or two, depending on if you're on blood thinners or not. It tends to last longer. Those are the biggest kind of issues that people have. And it's obviously not comfortable to have a needle in your eye, especially once the numbing medicine wears off. It does kind of ache a little bit afterwards. The most injections I've given somebody was over 100. So there's no real limit as to how many injections somebody can have. So that's, basically there's no limit there.
Somebody's asked Dr. Yang to confirm that it would be advisable to keep the A1C below 6.5.
Oh yeah, so it's a very good question. So if you look at the data, so actually I mentioned 6.5 is a kind of turning point. But if you look at the slope below 6.5, you see a gradual increase of retinopathy. It's not zero. Sugar is always lower is better. That's the case. So 6.5 is kind of turning point. You see sharp increase. Now, having said that, diabetes is an interesting thing in terms of complications. At the Joslin Diabetes Center, there was a study, I think it's still going on, for diabetic complications, looking at people with well-controlled diabetes and not well-controlled diabetes, and compared their complications, including retinopathy. Now, of course, overall, the patients with uncontrolled diabetes, they have worsened complications, including retinopathy. On the other hand, in the group of very well controlled diabetes, relatively 6.5, 7% A1C below, some people develop quite severe complications all over the places, heart attack, eye conditions. So it's very complete. Overall, if you look at the data, of course, A1C 6.5, the complications are reduced quite very significantly. It's day and night difference. But inside of the people with controlled diabetes, some people still develop complications. As I mentioned, it has to do with the genetic background, and it has to do with the cholesterol control. It has to do with the blood pressure control, the other factors together. So again, it's a comprehensive management, not just sugars. Sugars are important, and cholesterol important, blood pressure important, lifestyle important.
Yeah.
There is one for Dr. Yang, but it does seem a bit personal because they do mention a few medications. So Dr. Yang, I may just email that one to you after this. Sure. So I will go to the next one that says, does lowering blood pressure help glaucoma?
Not really. We haven't really seen that, but it does help diabetic retinopathy. So still control your blood pressure. And then special considerations for patients who have had a vitrectomy and later need cataract surgery in the same eye. Yeah, after having a vitrectomy, cataract surgery is more difficult. So you really want to have a good cataract surgeon do your cataract surgery after vitrectomy, because once the vitreous jelly is out of the eye, there's a lot less support for the lens during the cataract surgery. So a very good cataract surgeons are used to that. And so they know how to handle that. People who are novices or who aren't very well experienced with complicated cataracts should not really be doing those cataract surgeries.
That's great. Are there any other questions for our two star doctors this evening? If not, this lecture has been recorded, and after we edit it, we will be sending out the link to everybody who's registered for the event, and will also appear on our website. So we'll be sending that out. It'll take a little bit of time to get that posted. There are other diabetes lectures from our past community lecture series that are available on our website, eye.uci.edu. There's a lecture button in the left-hand column, and you can find information about diabetes and many other topics. The next lecture coming up is on March 16th, and it's with Dr. Idiri Wikrema on sags and bags. So if you haven't already registered, you might want to sign up for that and any others for the duration of the year. So Dr. Yang and Dr. Mehta, thank you so much for this great lecture. As always, we had a great turnout, and you're getting lots of compliments in the chat, so you can read those. And we will see you again soon, everyone. Thank you so much.
Thanks, everybody.
Thank you very much.
Thank you.
Thank you.
Thanks, Dana and Alex.
Hold on.